Welcome to the lower airways. So when we're looking at the lower airways, we're going to introduce two new cell types that we did not talk about with the upper airways because they weren't in the upper airways. So one of them is going to be simple cuboidal cells. So simple cuboidal cells are very, very small and thin, and you will see those in the next slide where I actually show you simple cuboidal and simple squamous. And simple cuboidal, they're just a single layer. They look like a little cube. Have a little dot in the middle of them. That's the nucleus, right? These are found in the bronchial. See, these are some of the smaller airways. As we move from the larger airways that are lined with pseudostratified ciliated columnar epithelium cells, then we're going to move down, and the further down the airways we go, the more simple the tissue becomes. So when we're getting to that transition zone, and we'll talk about the transition zone in a bit, we're going to run into simple cuboidal cells. And as we go through simple cuboidal cells in the transition airways, and we keep going down, and when we get to where we actually exchange gas, the CO2 and the O2, that will be when we start to see that simple squamous. So the simple squamous is also a single layer, very flat and thin, which is perfect because we want the thinnest tissue we can get to exchange gas between the alveoli and the bloodstream, right? So the thinnest this layer is of the tissue, the better, because that means gas will diffuse a lot easier across it, right? Especially when we get to, I believe it is chapter 4, when we start talking about diffusion of gases. That's going to be one of the big things, and we'll be going into all the science that you guys have recently gone over as well and applying that. So we're just adding two new cell types from what we did in the upper airway. So this is a picture of the different types of epithelium, and this is what we're seeing here is the simple cuboidal. So you start off with pseudostratified ciliated columnar, so that's here, and we're just going to add some animated cilia here, and there's lots of cilia. Normally there's over 200 cilia per cell, and I have some bigger and better pictures of that later on in the presentation. So we started with this. So right below the vocal cords we have this pseudostratified ciliated columnar. As we get further and further down the airway, we're going to transition to simple cuboidal. This is going to be in our transition airways. Makes sense that we're transitioning. And then we'll ultimately go to simple squamous when we get to the sites that actually exchange CO2 and O2. So the wall of the alveoli is actually this simple squamous, very thin layer, right? Because we would need to diffuse gas across it. And so that's going to be pretty important. So you might ask, why is the cell types changing? Well, I'm glad you asked, because the cell types changing allows for a change of function. The function of the pseudostratified ciliated columnar, which includes goblet cells, and there's even submucosal membranes that make mucus and all other stuff. The whole idea here is to protect and mobilize any like dirt, dust, pollens, pathogens, right? So that's the whole point of this part of the airway down here with the pseudostratified, is to protect and filter and create mucus and all that good stuff there. But as we get to the simple squamous, our function completely changes to no longer protection, because that's already been done, no longer filtering because that's already been done. Down here, our function in our lungs have changed to actually exchanging gas, the CO2 and O2, across the alveolar capillary membrane. It's that exchange of gas. So our function changes, and that's why we see the difference in the different types of cells. So your book has a beautiful graph or a picture that actually shows what type of cells are in what parts of the airways. So expect me to ask you what type of cells line the alveoli, what type of cells line the transitional airways, what type of cells line the primary bronchi, what type of cells line the first third of the nose, what type of cells line the posterior 2/3 of the nose or the nasopharynx, what type of cells line the oral pharynx. Like, that's all going to be asked of you, so be prepared to that. Make sure that you got that distinction between where all the cell types are down. So based upon what we've talked about so far, what do you see here? Name that cell, and you're like, why would I care? All right, I kind of actually like that question. Why does it matter to me? So when we're looking at these cell types, and it's here too, you can see that these are all lined up. They're in a cubed shape, so this would be simple cuboidal. Well, does that answer why would I care? A, that's cool that you were able to pick this out of a lineup. That's a pretty neat trick to bring out at parties. But B, the other thing is, besides nerding out, which is awesome, is that you actually get to see what part of the lungs that you're looking at. So if you were to take an autopsy and you were to take a pair of lungs and you were to take a sample from the pair of lungs and put it onto a slide and look at it under a microscope, you can actually tell that you're looking at transitional airways, right? So this is really cool, especially if you're going to go into diagnostic respiratory care where you're actually doing things like endobronchial ultrasounds or things that where you actually go into histology and pull samples from people's lungs that are still living, right? So, and then we're going to look at them under a microscope and help with the diagnostic purpose of this patient. So it's pretty neat to actually see there is application to all this besides understanding the functions changing. You actually can see what type of cells are most affected by a disease process or by a pathogen process. So it can actually help us understand diseases and pathology a lot better too, looking at these slides and understanding which cells are most affected by different pathogens. It's pretty cool. Alright, so this is the simple squamous cell when we get down to it. Notice these are very flat, very thin cells. They have a nucleus that's right in the center there. These are the cell boundaries that I just outlined there. So this is what makes up the alveolar wall, a bunch of these connected together. So the alveoli is not a perfect sphere, it's a bunch of these little patches of simple squamous cells sort of connected together to ultimately form the wall of the alveoli. So this is sort of what you might see if you were to take a tissue sample from someone and see that there's a bunch of blood or white blood cells just invading this tissue, right? I wish I put some examples in here for you guys, but I did not. So when we're looking at this, you can sort of see that that's the area that's most affected by this disease or this process on this patient. Or you can tell if that's where their hemorrhage, their bleeding was coming from, was their alveoli, right? Then you can sort of see where that process is. So these are different things we can get from a bronchial alveolar lavage. So there's things that we can use to actually get this information and help diagnose and treat these patients. So pretty interesting stuff. In critical care medicine, you may or may not have to, know these cell types into this depth. But if you do work critical care and diagnostic medicine, which I did, then it's something that can come in pretty handy. And understanding the pathology of what's going on and looking at the histology can give you a big clue on how best to take care of that patient. Alright, so the lower airway. So those were just the new cell types that we're introducing here. So this is everything below the vocal cords. So this is going to be pretty intense, just like the upper airways. So let's get started. So after passing through the larynx, the gas that you breathe in enters the tracheal bronchial tree. So this is a fancy term for pretty much anything below the vocal cords until we get to the terminal bronchial. So this takes up a lot of space, but it doesn't take up everything. So the alveoli actually aren't considered to be part of the tree, and we'll talk about that in further detail here. This is mostly branching airways, right? So this is just branch after branch after branch. So if you go outside and you look at a tree, right, and then you're going to see branches and more branches and more branches and more branches and so on and so forth, right? So the tracheobronchial tree starts with, let's just call this one the trachea, and then we're moving on to all the branching or generations or orders. And there's about considered to be 28 generations. There's a really good figure in your chapter 1 of cardiopulmonary anatomy and physiology. So please look through that chapter. I guarantee you if you read the chapters and you do the workbooks, you will score better than if you do not. I guarantee you that can be very helpful. So about 28 different generations or different branching of the airways as we look through. So let's go into some of these generations. The first part we'll talk about is just that dichotomous branching part we mentioned just a second ago. And when we're looking at dichotomous branching, the big thing that helps us here, and this is a much better picture than what I could do down here. If you see all these pictures down here, much better pictures than what I can draw. And this is something that happens in nature, right? We already talked about, like if you're looking at a tree. As we're looking at the dichotomous branching, every time we have a branch, more branches come off of it. And then off of that branch, 2 more branches. And off of that branch, 2 more branches will come off, and so on and so forth. So if I were to look at this, so you're looking at letters A, letters B, letter C, and letters D, all right? Between all of A, B, C, and D, which one do you think has the most surface area? So if I gave you a bucket of paint and I said the bucket of paint will last on all 3 of them except for one, or all 4 of them except for one, which one would, the bucket not cover? Well, there's going to be a lot more surface area to cover in letter A because of the dichotomous branching. There's a lot more surface area than if we just had, hey, an alveoli here, an alveoli there, or a bronchus here, a bronchus there. It's because every branch has 2 branches that come off of it. It's getting to the point where we're having mathematically a larger amount of surface area. This is good. The more surface area that we have, the more we can filter, the more we can humidify, the more we can get gas into the deep parts of our lungs. So this is perfect, right? So when we're looking at this, this is going to be an important part that we'll bring up in a little bit here too as well. So dichotomous branching, good for surface area. All right, this is the big picture. I always like looking at the big picture, and then we'll zoom in on each of these more individually. So the thyroid and the cricoid cartilage. The cricoid cartilage, remember, is your only complete tracheal ring. So you can feel this on yourself right now. If you feel it for your Adam's apple, go ahead and palpate on yourself. Feel for your Adam's apple there. And then if you feel right in between the Adam's apple, there's this little tendon. That's where you'd put your cricothyrotomy if you had to do an emergency airway. And then the immediately below the thyroid, the next bump that you feel, like the outward protrusion you feel, is your cricoid cartilage. That's actually an important landmark because when we're looking at the cricoid cartilage, it's the only complete tracheal ring. All the other ones are incomplete, right? They're incomplete posteriorly because, remember, what anatomically sits behind the trachea? Well, the esophagus sits behind the trachea. So we need the esophagus to be able to expand and collapse in order to allow food and water to go into our stomach. And so all the rest of the trachea has incomplete rings in the back. There's only one complete ring, that's cricoid cartilage. Well, this is important to you because let's say we're trying to intubate someone and put an endotracheal tube into someone's trachea, right? So we're trying to intubate, but we can't see the vocal cords because the airway is very anterior. We can't get a good view. Well, one of the tricks that we might do is the intubator might ask, or if you're intubating, you might ask, can someone put pressure on the cricoid cartilage? Right? Can someone give me cric pressure is what they would say. And that's where you push down on the cricoid cartilage. So by pushing it down, you're pushing it inferiorly. We're assuming the patient's supine. So the patient's laying on their back and you're pushing it down. You're pushing it towards the ground. That will allow a better view of the vocal cords and might make it easier to intubate subsequently. So this is an important landmark and you can feel it on yourself, and then you will also be asked, if you work critical care medicine, to probably palpate it and locate it and do this procedure during an intubation here and there. It's not done during every intubation, but just to ones where we might need that extra view. Then we'll go into our tracheal rings. Usually there's about 15 to 20 incomplete tracheal rings, 1.5 to 2.5 centimeters in diameter. Right? These are all numbers that you'll need to remember, and I'll make a point to say these are all numbers you need to remember. So we have the tracheal rings. Once we get to the end of the trachea, we have a bifurcation. This is the fork in the road, if you will. The bifurcation of the trachea to the right and left bronchi is what's known as the carina. The carina is the separation, or the point at which the right and the left bronchi start to form. So it's the separation of the trachea into the right and left main stem. So from here, the gas will either go to the right side or to the left side. And then we'll talk about the angles being different on the right bronchus versus the left bronchus, and why that's important a little bit later. But the carina is that bifurcation, it's the fork in the road. And the big thing about the carina to remember, and so that way we'll repeat it later on as well, is that it has vagal stimulation as a part of it. So if someone intubates and they push the tube too far into someone's trachea and it's sitting on the carina, it's pushing against the carina, it's touching and stimulating the carina, it will actually cause vagal stimulation, which will then decrease their heart rate and decrease their blood pressure. Like, why is that important to know? Because that's happened, right? Just like the whole State Farm commercials, we know a thing or two because we've seen a thing or two. So when I had this happen, I still remember the room that this happened the first time, so it's not the only time this has ever happened. We were in a room and the physician had just intubated the patient and the tube was too far. And the reason why I knew that the tube was too far in their trachea is because this is what started happening. Their heart rate started to decrease, their blood pressure started to decrease. It was pretty immediate. So I asked the doctor, because I was trying to assist them with other things at the time, to pull back at least 1 centimeter or 2. So they pulled back 2 centimeters, and sure enough, the heart rate started coming back, and so did the blood pressure. So it was that vagal stimulation from it hitting the carina that told me that this was too deep, right? So pretty cool. There's a lot of good things. There's a lot of good knowledge that goes along with knowing your straight anatomy and why and what's there. So after we get through the main stem bronchi, we go to ultimately down to the bronchioles. So this is the smaller parts of the airways down here. And then we'll talk about the transition from the bronchioles into the respiratory zone eventually. So let's talk specifically about the top part of the tracheobronchial tree. It's divided into 2 general zones. One is the conducting zone, and the other one is the respiratory zone. So the conducting zone is different in function than the respiratory zone. So they both have different functions. Okay, that's why we separate the two. It makes a difference because one does one thing, the other one does something else, something completely different. So it's almost like fraternal twins. They're not identical. They were together, but they can be completely different people, even though they shared the same space for a little while. Well, same thing here. The conducting zone, it has no gas exchange, so it's like the bulk movement of gas. So think about like the highway. Think about I-25 or I-70 or whatever highway your brain thinks of, right? It's the movement or the transport of gases into and out of the lungs. So this is all about transporting gas into and out of the lungs. It's like a highway. It's all about transport. It doesn't actually do any CO2 and O2 exchange with the bloodstream, so nothing's going on with the bloodstream here. This is all about moving gas. And when we get to the respiratory zone, that's where our function changes. This is where we actually exchange CO2 and oxygen, right? This is the actual exchange, or where external respiration happens. This is the respiratory zone. And the respiratory zone has no cartilage in it. The conducting zone has cartilage in it. Why is that important? Because the functions are different. Conducting zone, it's all about transport of gases, right? It's about moving gas into and out of the lungs. And it needs structure. It needs to keep the airways open and patent as they can so gas can travel uninterrupted, right? It's like keeping all the lanes of the highway open. So we need the cartilage to sort of give the airway structure to keep all the lanes of the sort of airway highway open, right? We need that structure. Now the respiratory zone is where gas exchange happens, so that's the alveoli. They need to be able to expand and collapse to allow oxygen in and CO2 out, right? So that's one of the big things there. They need the oxygen in when we're breathing in, and then that CO2 out when we're breathing out. So the part of the lungs that actually opens up and you can see the chest rise or the lungs moving is actually the non-cartilaginous airways. So if you see a pair of lungs, right, and someone's squeezing a bag that's connected to a pair of lungs, you're seeing the actual respiratory zone. You're seeing the non-cartilaginous airways expand when they're doing that. So it's not the trachea, right? Your trachea doesn't move significantly when you're breathing. It is your respiratory zone, your non-cartilaginous airways. This is good. You don't want these to be firm. You don't want them to be secure because that allows for more movement, and that way we can move more CO2. Now here's a caveat. I know it's just like learning English. We're like, hey, this is the rule except for this, and this exception, right? There is another zone, and this is called the transition zone. So the transition zone is where there's no cartilage, but they don't exchange gas yet. So this is actually considered part of the conducting zone because this is still where gas moves but doesn't exchange gas. It doesn't exchange CO2 and O2 with the bloodstream. There's no communication with the bloodstream in the conducting zone. There's no communication with the bloodstream in the transition zone either. So think of the conducting zone, like I said, as a highway, and then your on-ramp and off-ramp to the highway would also be the transition zone. So the transition zone is where you're either slowly getting onto the highway, like an on-ramp, or slowly getting off of the highway, right? The off-ramp, like you're decelerating. And so that's that transition zone. The transition zone does not exchange gas, therefore it is considered part of the conducting zone. So if I ask you in the future, tell me of the cartilaginous or non-cartilaginous airways that don't exchange gas, you'd be talking about the transition zone. That's what I'd be looking for there. So it's non-cartilaginous, it doesn't have cartilage, but it also does not exchange gas. So this is the transitional airways. All right, so let's look at histology. The histology of the tracheobronchial tree. Don't let the word histology trip you up. Histology literally means tissue, right? That's all we're looking at. So if doctor's like, we need to do a sample for histology, that's just them saying, hey, we need to grab a sample of tissue. Like not of like Kleenex tissue, but of like the patient's tissue of their tracheobronchial tree, right? We'll get a pair of forceps. We'll actually grab and tear a little tiny piece. I mean a little tiny piece, and we can send it to the lab and look, and hey, they're simple cuboidal. That was transitional airway. Hey, what do you know? Applying stuff already. So when we're looking at the histology of the tracheobronchial tree, there are 3 layers. The first layer is the innermost layer. So the innermost layer is the epithelial lining. This is the closest to the lumen. So epithelial, E-P-I-T-H-E-L-I-A-L, epithelial lining. There is the middle layer, and this is called the lamina propria. All right, this is the middle layer. I'll just put mid. The lamina, L-A-M-I-N-A. Once again, L-A-M-I-N-A, and then propria, P-R-O-P-R-I-A. So the lamina propria is that middle layer. This one has the basement membrane that has the tissues to secrete things. It also has all the nervous tissue, smooth muscle, submucosal glands. All the big meat part of your tracheobronchial tree is in that lamina propria, okay? And then your outermost layer, and almost like an exoskeleton, is the cartilaginous layer. So that's the last one there, C-A-R-T-I-L-A-G-I-N-O-U-S. That is the cartilaginous layer. So the cartilaginous layer is, like I said, an exoskeleton that helps give everything structure, sort of like a scaffolding, the scaffolding outside of the Leaning Tower of Pisa. It helps give it structure and keeps it open and keeps it moving. So the 3 layers of the tracheobronchial tree, the epithelial lining, the lamina propria, and the cartilaginous layer. You need to memorize that. Memorize that, memorize that. I will ask you that over and over again. All right, so let's look at the top part. So this is just a different view of the three layers. At the bottom here is your cartilaginous layer. That's the one we just talked about. That gives everything its exoskeleton. So that means we're moving from the outside to the inside here. So the next layer, besides the cartilaginous layer, is the lamina propria. And this is one where we talked about where you have the basement membrane here. And the basement membrane I like to think of as the nursery. That's where all the new cells are being created. All the little baby cells are there, right? They're developing, they're growing. This is also where you have smooth muscle. So when someone has a bronchospasm, when the airways are contracting in and causing like an asthma attack, this is where it's located. It's located in the lamina propria. And then you also have submucosal glands that create secretions in here for mucus ultimately. So you have goblet cells that are in the epithelial layer, and then you also have submucosal glands that are in the lamina propria, and both of those make mucus, right? Both of them make mucus. So if I ask you that in the future, which of the following make mucus, right? You're going to say submucosal glands and these goblet cells, right? That are in there. So goblet cells and submucosal glands, both of those make mucus. So when we're looking at that, that's what you will see there. And this is, notice here, see this parasympathetic nerve that's located in the lamina propria? When we get into pharmacology, that's going to be very important to remember, because when we give medicines like a parasympatholytic, we're blocking parasympathetic activity, which can do what to mucus production? Well, it's going to decrease mucus production, because remember, your relax and digest creates mucus. So that's your parasympathetic stimulation. So if we're blocking parasympathetic stimulation, we're not going to make secretions. So we can actually dry out someone's secretion, which can be a good thing and bad thing depending on different situations. So question for you when we're looking at this, before we get any further, we're looking at the epithelial layer. What type of cells do you see here? Is this simple squamous? Are these cuboidal? Or are they pseudostratified cilia epithelium columnar? So the epithelial layer is PSCC. It is pseudostratified cilia epithelium columnar. So right, you see that it's columnar in shape. It has cilia hanging out up there, all the little hairs, and it's up there. And so the cilia beat in what's called the mucus blanket. I know, it sounds warm. So when you're making a peanut butter and jelly sandwich, and I know it sounds like I'm getting off on something weird here, but when you're making a peanut butter and jelly sandwich, which goes on top? The peanut butter or the jelly? The jelly goes on top, and that's how I remembered which of the layers would go on top. So there's the sole layer and the gel layer, right, that are part of the mucus blanket. And so the sole layer is very thin and watery, and it allows for that cilia to move in there. And the thing about the cilia here is it's like walking, you want that to be thin and watery. It's like walking down a concrete path. There's not much that's going to impede your feet from moving. But as you get to this thick, sticky gel layer, that mucus that becomes very viscous, and you want it to be viscous. You want it to be thick and sticky, because that means it'll trap pathogens and dust and particles. Anything that you're breathing in that you shouldn't be breathing in, it'll trap it in that thick, sticky layer. So the cilia will beat in the very thin, watery layer, which is good. That allows for that the cilia to move very freely, and the very tips of the cilia are going to move that thick, sticky mucus part, the gel layer. They're going to move it, and that's that mucociliary escalator that we'll be talking about here. So I beat this slide to death here, but we'll talk more about all of these. The epithelial lining, so we'll talk a little bit there. This starts off as pseudostratified ciliated epithelium columnar, and as we get to the transitional airways, it will transition to simple cuboidal. So remember, the smaller the airway gets, the more we transition to a smaller cell. Cell types will progressively change from columnar to cuboidal, C-U-B-O-I-D-A-L. to cuboidal. And then as we keep going, the cilia will disappear, right? Do you know that cuboidal does not have the cilia here, right? They're changing function. So things are starting to move and disappear because we're starting to go into an area that changes function. In this area, in the epithelial lining, we do have mucus glands, right, the submucosal glands, and we also have goblet cells, right? Good idea for a Halloween costume. You could be a respiratory goblet cell. I thought that would be fun. Secretes mucus. It secretes and makes mucin to make mucus ultimately. So this is if someone has a disease like bronchiectasis, this is what creates all that thick, sticky, tenacious mucus that can be in there as well. The epithelial lining, well, what holds the epithelial lining together? Well, it's anchored to a basement membrane. So this should be basement membrane that contains basal or baby cells, right? That's why I called it the nursery earlier, because it's adorable. It reserves cells that replenish the mucus and ciliated glands when it's time for them to be replenished. We already have the backups ready to go. This is the bench if you're looking at it in a sports analogy. Next line, you have roughly 200 cilia per cell. That is a question that I want you to remember because it's a very important thing to look at. It's knowing the more you have your cilia motility, the better. And that means if your cilia get immobilized, like let's say cigarette smoke will actually paralyze cilia. The more you immobilize cilia, the more problems with mucus accumulation you will have. And that's one of the reasons why if someone goes under general anesthesia in paralytics, we're going to be worried about mucus plugging and actually them developing a pneumonia because that cilia hasn't been moving, it's been paralyzed, and so they're more prone to an infection because their ability to move pathogens out of their lungs is decreased. So important to know that cilia play a big role and that there has to be a high number of them for everything to function. Best picture of cilia. This is them on their good day. All right, so this is there. You see all their cilia just sticking up in that wave-like function. So here, invisibly, you have the sole layer, where most of these cilia are beating, and then on top you have a very thick, sticky layer called the gel layer, right? And it's the sole layer that it's thin and watery that allow these cilia to move freely, and the very tip of the cilia are actually strike the gel layer that's thicker and more viscous that traps all the particles. Let's say here is a nice good dust particle, right? It traps it and then allows it to move in there. So here you can see a good picture too of the goblet cell that eventually helps secrete a bunch of mucus and mucins that helps it. And then finally you can see the epithelial cell nucleus as well as the nursery, the basement membrane. The basement membrane is what attaches the epithelial lining to the lamina propria and also houses the cells that will later replenish it. More about the epithelial lining. You have the mucus layer, also known as the mucus blanket, right? The mucus blanket, in essence, sounds warm, covers the epithelial lining of the tracheobronchial tree. This is good. This whole blanket, like I said, helps trap pathogens and mobilize them out so that way they don't end up going down to the alveoli, they don't end up going into the bloodstream. So this mucus blanket is produced by goblet cells and submucosal glands. Goblet cells and submucosal glands. Goblet cells and submucosal. Sounds like I want you to know both of those, right? And not only that, but that's not the first time I've repeated that to you either. So the goblet cells themselves are located in between the epithelial cells. See that previous slide there. And the submucosal glands extend into the, it's two words, lamina propria, right? I don't have enough room to write all that in there. Lamina propria is where they go into and are innervated by the what type of nervous system? Sympathetic or parasympathetic? The hint is relax. right? And the way I think of the difference between sympathetic and parasympathetic, you think of a parachute. Do parachutes slow people and things down, or do they speed people and things up? Right? They slow everything down. So this is the parasympathetic nervous system, and so they slow everything down. They relax and digest. So they're going to secrete or create mucus in this layer, right? And this is innervated by the 10th cranial nerve, is what you're seeing ultimately here. This is that stimulation that comes from that 10th cranial nerve. The reason for the mucus blanket is for cleansing, right? Filtering and protecting, right? Cleansing, filtering, and protecting. And when we're looking at this, that's one of the big things about the epithelial lining. It's a cleansing and protecting and filtering mechanism. That's part of the function here. And it's composed of 95% water, right? The remainder is carbs, proteins, lipids, cellular debris, foreign particles, DNA, all that good stuff is there too, but it's mostly water. So let me ask you this application question. If someone is dehydrated, right? If someone is dehydrated, what will happen to their ability to make mucus to protect their lungs from infection? Will it increase the ability to make mucus to protect their lungs, or decrease the ability to make mucus and protect their lungs? Right? It will decrease that ability to make mucus and protect their lungs, and therefore open them up to a higher chance of infection. And so that's one of the reasons why dehydration can be very dangerous for someone, not only for blood pressure and organ function, but also for things like pulmonary function as well. This is just different pictures. I love taking these out of your books and out of different books that are out there. Once again, this is the good side view of the epithelial lining. And here, if we were to take like a helicopter and look at the top of a forest, right? This is the same thing. We're looking at the superficial view. We're looking down at the top of the cilia, and that's what the cilia would look like from the top view if you're looking at that top picture. The side picture, and then here, over here, is an animated picture which gives you a little bit more detail about where the stem cells are and where the cilia are. It draws better distinctions than what you might see with the actual histology pictures. The mucus blanket itself, the body produces, we're talking about inside the lower airways. We're not talking about the nose. Remember, we talked about that one being like a liter to 1.3 liters, somewhere in that area of nasal secretions, and most of that goes into your stomach. This is the lungs. So the lungs, the mucus blanket, produces 100 mLs of secretions, right? This is a number you should remember, right? Number you should remember. The viscosity of the secretions increase as you move from the lining to the lumen. That means that that gel layer is going to be very thick, right? It's the innermost lumen. It's going to be very viscous, and that is your gel layer, right? The layer adjacent to the epithelial lining, so the ones closest to the tissue, is going to be very thin and watery. What's that called? Remember, that's the sole layer. The sole layer is very thin, watery. That's going to allow the cilia to beat very freely overall. So the gel and the sole layer are your two ones. Which one is thick and sticky? The gel layer. Which one is thin and watery? The sole layer. Which one is on top? Well, the gel is going to be on top. So these are all things that you should be going through. The cilia, they move in a wave-like fashion, like I always talked about before. They beat at a rate of, so this is an important number to remember, 1,500 times per minute. 1,500 times per minute through the less viscous. Which one does the cilia move mostly in? The sole layer or the gel layer? The sole layer, right? This is something we already talked about. And they strike the inner layer, so they strike the bottom part of the more viscous, the very thick, sticky one that's on top, the gel layer. So the gel layer is going to be that more viscous layer. So they strike the gel layer to help move it, but most of their movement is in the sole layer. So this is going to move them, or move all that mucus at a rate towards the larynx at a rate of 2 centimeters per minute. So that's another number. Like I would make a separate 3x5 card of all important numbers. Like these are the important numbers Derek stressed, right? So this is something I would recommend. So they move at 1500. The cilia beat is at 1500 times per minute. So that's the beat. If it made its own song, it would be very, very fast because it would be at 1500 beats per minute, right? 1500 times per minute. And what's the rate, or how fast does the mucus move towards the trachea? Well, it moves at 2 centimeters per minute. That's that whole, if I were to have a trapped pathogen, what's the distance it would travel over the course of a minute on its way out? Well, that's about 2 centimeters per minute. So the cilia, they're beating really fast. The rate of the mucus blanket movement is also really fast comparative to what we're looking at. The cough mechanism is what ultimately will move the secretions above the larynx into the oropharynx. So before we move on to this slide, before I get deep into this slide, let's talk about the cough. So there is 4 stages of the cough. The first one is going to be irritation. Irritation, so this means you inhale a particle, a dust, or a fume, something that irritates the lining of your lungs. So you're going to have that initial irritation, whether it comes from the inside or the outside. Mucus moving up that has lots of thick stuff in it, so irritation, that's moving up. Then the next part is going to be inhale, right? You're going to take a deep breath, right? You're about to cough. Are you going to take a deep breath? Yeah. So irritation, inhalation. And then what comes after you inhale before you cough? Do you just cough, or do you actually do something with your epiglottis and you close it? Well, you close your epiglottis, you back pressure the secretion, so you're going to compress, right? So you get the irritation, you inhale, you compress, you close the back of your throat, and then finally you expel, right? This is where you get rid and expel that secretion overall. So the cough mechanism, there's actually 4 parts to it: irritation, inhalation, compression, and expulsion, right? So this is something I want you to remember, something that your Egan's book actually talks about. I'm not sure how in depth your pulmonary A&P book talks about it, but something I definitely want you to know. I expect you to know it, so hopefully wink, hint right there. All right, the mucus blanket itself. Let's get back to where we're at on the slide. It's a cleansing process called the mucociliary transport. So muco, M-U-C-O, C-I-L-I-A-R-Y. So the mucociliary transport, or also known as the mucociliary escalator, right? The escalator, just like what you see at a mall or at the museum, right? Or in Vegas, right? These are a mucociliary escalator. It's helping move secretions up and out. So those are just synonyms, right? Mucociliary transport, mucociliary escalator. Those are just different ways of talking about this whole mucus blanket system that we have going on. So ultimately, this is going to be important, right? This is almost like I would test you on this type of information here. What will slow the rate of the mucociliary escalator down? What will slow the mucociliary transport down? What makes it hard for us to clear secretions? There's a lot of things. Number one on the list is cigarette smoke. What happens when someone goes out? Have you ever known a smoker and what's the first thing they do when they wake up in the morning? They're going to get up and they're going to cough like crazy. Because when's the last time they had a cigarette? Well, forever ago. And so that means their mucociliary blanket's working. It's trying to remove all that tar and all that bad stuff that they've been breathing in. So what do they usually do first thing in the morning when they're coughing like crazy? They go take a smoke, right? They go smoke. And that will paralyze the cilia. And so if we paralyze the cilia, it's like breaking the engine of an escalator, right? It's not going to move. And so they're going to actually keep those pathogens, dust particles, all those things, the tar, all that bad stuff that's in their lungs, going to stay in there. So that's one of the reasons why these people that smoke are also more prone to infections. They're more prone to pneumonias. They're more prone to getting the flu. They're more prone to all these bad respiratory diseases because the cigarette smoke actually impedes their ability to get rid of bad stuff. So say hello to your doctor bill, right? Unfortunately. So cigarette smoke, dehydration, we talked about this, making the mucus thick and sticky, especially if it's the sole layer that gets dehydrated. You're really not going to be able to mute that mucus blanket very much. The next one is a very important one to remember, positive pressure ventilation. That's us. When we put someone on mechanical ventilation, when we put them on life support, a breathing machine, we're pushing gas into their lungs, and that's going against the direction of the cilia. Remember, the cilia are beating to get things up and out of the lungs. Well, when we put someone on positive pressure, which direction is the gas flowing? Well, the gas is flowing the opposite direction, so it's actually pushing. It's like a backwind. It's like a wind pushing the cilia the other direction. So the mucus actually doesn't move. Even when we put someone on a wean where we let them breathe on their own on the ventilator, we'll see that where once we switch them over to where there's less positive pressure, we'll see some mucus work its way on up. Well, there you go. It's the mucociliary escalator saying, hey, we can actually move mucus and let's get it out. So that's not uncommon to see that. So positive pressure ventilation can make it more prone for us to retain mucus, which makes people more prone to infection while they're on positive pressure ventilation, more prone to like pneumonia infections while they're on ventilation. Endotracheal suctioning, especially, what happens here is we're actually putting a plastic or PVC or whatever type of material the catheter is made out of, and we're pushing it and we're jamming it down into the trachea. And what do you think happens to the cilia when we're just jamming a giant plastic thing right at it? Well, it's going to stun it. It's going to cause trauma to it. And so endotracheal suctioning also can stunt mucociliary movement and ultimately the ciliary beat. High FiO2s and hypoxia also will cause issues. Hypoxia, your body doesn't want to do anything when it's hypoxic, let alone move things like your cilia. It's not a high life function according to your body. Your high life function would be sending blood to your brain, not making sure your cilia are beating. So too much FiO2 or too little oxygen in the bloodstream can easily decrease mucociliary movement. Atmospheric pollutants, right? This is about the concentration of the environment. So let's say a neighboring state has a bunch of forest fires going on and we're getting a lot of it. Then you're going to have a lot of pollutants that are stopping and clogging up the system. It's like driving cars during rush hour versus driving a car during a non-rush hour on a highway. The more cars there are, the slower things are going to move, right? And that's what you're looking at here. A lot of pollutants all at once, so we're going to slow down that mucociliary escalator. That makes you more prone to infections. General anesthetics, we already talked about this, that either paralyzes the cilia, so it makes the people more prone to a post-operative pulmonary infection because now we can't move mucus and normal pathogens that we would normally get rid of that wouldn't have caused an infection, and now they're going to sit there. And remember, your lungs are a warm, dark, humid environment, and so that's just going to culture and grow that bad stuff there. And finally, the last one here is parasympatholytic. So a lytic is means that it blocks. So this is a drug that we can give to someone that blocks parasympathetic stimulation. We're like, hey, what's an example of this? Why would I need to know this? Well, let me give you an example. Atropine. Atropine, A-T-R-O-P-I-N-E. Atropine is a drug that we can use to give heart rate, to give an increased heart rate to a patient. Also, they used to use it. We don't currently as much as far as when I'm recording this. We also used to use it to dry out the airway. We also used to use it to make sure there's not as much secretions before they would do things like a bronchoscopy or to decrease vagal stimulation. before we would do a bronchoscopy procedure, so there wouldn't be as much effect from the vagal stimulation. So there's other drugs that we can use to atrovent, or ipratropium bromide is the other term for atrovent, and that's a parasympathetic. It blocks parasympathetic stimulation. Well, that's good in one aspect because that could help relieve bronchospasm. So there's a number of things that can decrease mucociliary movement. So let's say you have someone that has a lot of mucus plugging issues, okay, and they're on atrovent, which is a drug that's a parasympathelytic. Then you, being in this class, right, in your pulmonary A&P class, would know, hey, talk to the care team. What are your thoughts on keeping them on this drug if they're having lots of mucus plugging issues? And then you can have that professional discussion about if it's appropriate for that patient to still be on that medicine with a mucus plugging issue. The lamina propria, this is the next one. So we just finished talking about the epithelial layer. Now we're going to the lamina propria. Remember, this is that middle layer as far as the tracheobronchial tree is concerned, right? The histology. This is has a submucosal layer. So the submucosal layer means it's under the mucus. Right, fancy word for it's under all that, the soul and the gel and all that stuff. It has lots of fibrous tissue with blood vessels, lymph vessels, nerve intervention. All that stuff is in here. This is where a lot of stuff happens. And then it has what type of muscle that's in your lungs. Is it cardiac, skeletal, or smooth muscle? Right, so this is smooth muscle that wraps in spirals clockwise and counterclockwise. And the way I like to think about this is when we're looking at like the DNA helix, right? When we look at the where it's sort of like that 3D helical motion that sort of surrounds the airways, and it sort of weaves its way all the way down. And there's some better pictures in here, clockwise and counterclockwise. And this goes all the way down to the respiratory zone. So that smooth muscle starts in the tracheobronchial tree. It starts up in the high airways, in the conducting airways, and it even goes into the respiratory zone. So this is where we can constrict and dilate these, and that's the lamina propria that we're usually trying to send all the respiratory medications to help relieve things like bronchospasm to. The lamina propria has surrounded by a thick connective tissue layer called the peribronchial sheath. So peri means surrounding, bronchial, right? That's what it's surrounding, the bronchi. So peri, P-E-R-I, B-R-O-N-C-H-I-A-L. This is the peribronchial sheath, S-H-E-A. The peribronchial sheath. So this is like a little saran wrap layer that sort of holds this together. Some people might call it like a fascia, right? Like the muscle having a fascia to it. I like to think of it as Spanx, coming from the ballroom world. Cornell holds everything together, right? Gives it structure, holds it all together. So if that's how you think of it, that's how I think of it anyway. You can use that if you want mentally. If that doesn't help you, then pretend I never said it. Alright, so this is the big picture here. This is where we're looking at the goblet cells, submucosal. So we have the epithelial layer here. Then we have our lamina propria layer here that has the mast cells and the submucosal glands and the smooth muscle. And then the mast cells are going to be an important part to take note of here when we're looking at mast cells, because mast cells, when they degranulate, when they become unstable, they're going to release a bunch of really bad things. That's what the next slide is going to be about. That can ultimately cause the bronchial muscle to then go into spasm and contract. That's not good, especially if it does it in a severe case. And the whole idea behind bronchospasm and mast cells degranulating and causing all this stuff is a protection mechanism. It doesn't want whatever is causing this irritation to go deeper into the lungs, so it's trying to close it off, right? And that's the whole idea. But if it closes off too much of the lungs, that's when we get to a bad situation. And that's what we see with asthma, where it's too sensitive and it's going to cause an issue with them just being able to live. So the lamina propria has mast, M-A-S-T, that's what I was just talking about, is the mast cells. Mast cells that are located here. The cytoplasm is loaded with granules containing mediators of inflammation, I-N-F-L-A-M-M-A-T-I-O-N. Yeah, my stylet's not good, but there you go. Mediators of inflammation. So this means this is all the bad stuff that happens. And I have an animation on the next slide that shows that whole degranulation. It's in your book too. Heparin gets released, histamine gets released. And this is why you might have people that have like allergic asthma on an antihistamine, right? Like a Claritin or something like that. And so that helps stop this whole thing from happening. It will release a slow-reacting substance of anaphylaxis, platelet activating factor that thins the blood cells, eosinophilic chemotaxic factor of anaphylaxis that dilates and helps send more blood to the area. So this is not so great for allergies. This is something where you're looking at humoral immunity, and this is where IgE is the antigen here, and so we'll see that in the next slide. So this is coated with a lot of receptors in the lamina propria that trigger exocytosis of the granules, right? Which is a fancy way of saying that this it degranulates or it bursts, is ultimately what that whole thing is saying. The mast cell will degranulate or burst. And that's what causes all this bad stuff to be released. So that's what pops the water balloon of all this bad stuff, is the exocytosis or the bursting of a mast cell. So once this mast cell is destabilized, it can be pretty dangerous for patients that have like allergic asthma, and that's why it's important for them to know their allergies and to actually know what pollens they're sensitive to, or what trees they're sensitive to, or so on and so forth, because that can be a big factor into their daily living. This is that flow chart, and this is from your book too. This is where you're looking at the antigen and then it being released, and here, like I talked before, the IgE is a part of here, and where the IgE, it gets desensitized to the cell, which then releases all this bad stuff here. This is the bad stuff: that histamine, heparin, slow-reacting substance anaphylaxis, the platelet activating factor, the eosinophilic factor, right? Of anaphylaxis, and so all that stuff will eventually be released, and when that happens, this is when you have your asthma attack, right? That bronchospasm. So the whole thing here is this whole process. Why do my lungs do this, you might be asking, if you have asthma, or why do asthmatics' lungs do this? Well, the whole thing is to try to capture the antigens. It's trying to stop it from going further down, and there's different drugs like anti-leukotrienes. Like, look at this part here. Right, the leukotrienes. We can give drugs like Singulair, also known as Montelukast, or that's the other name for it. Things like that can help prevent these asthma flare-ups because we're stopping the bronchospasm before it happens. We're blocking the ability for it to cause a smooth muscle reaction, or at least reducing it. Okay, so we've gone through the epithelial lining, we've gone to the lamina propria, and then what's the outermost layer? It's the cartilaginous layer. So when we're looking at this one, this layer progressively diminishes as we get further and further down into the lungs. So as we get further and further down, the cartilage is not in bronchioles less than 1 millimeter in diameter. Okay, so this is further and further down, the smaller and smaller the airways get, the less cartilage is found. And this is from fetal development, right, in utero. The smaller we get, the more developed the lung tissue is, then that's when your respiratory zone starts to develop. We're changing function. We go from being movement of gas in the conducting airways to now exchanging of CO2 and oxygen. So we're changing functions. We have a change in function. So bulk movement to now gas exchange, right? And so that's what we're looking at here. No longer in the gas exchange areas do we need cartilage, right? That actually hinders our ability to exchange CO2 and O2 if we had cartilage there. So that's as we're moving down. We do not have cartilage less than 1 millimeter in diameter. That's a number that you should remember. All right, so this is the big picture. I always like showing you a big picture. This one includes the peribronchial sheath, or the sphinx, if you will. This is great. And then I always like looking at this too, because in this picture you're seeing, see how thick and dense the cartilage is, and we're looking at the trachea. And as we move down, let's look at the left lower lobe. Do you see where I circled the left lower lobe there? When we're looking at the left lower lobe, how much cartilage do you see down here? Right? Very few cartilage. So this means we're transitioning to a change of function from the movement of gas to the exchange of gas. So that's one of the reasons why I like looking at this picture and going over it with you guys. All right, the lower airways. So we're looking at the cartilaginous airways, and like I said, your book breaks this down a lot better than this slide. So the trachea. The trachea has a cartilage, of course, the mainstem bronchi, the lobar bronchi, the segmental bronchi, the subsegmental bronchi. These are all in the conducting zone, right? You also have the bronchioles. And the terminal bronchioles. Right, bronchioles plus the terminal bronchioles. And these both are the bronchioles and the terminal bronchioles. They are part of the conducting zone, but do you remember what's special about these? They're less than 1 millimeter in diameter, but they do not exchange gas. So they're part of the transitional. That's right, so these are part of the transitional airways. So they're non-cartilaginous, right? But they're part of the conducting zone. So you should know what's cartilaginous in the conducting zone and what's non-cartilaginous in the conducting zone, right? I hope that makes sense to you. So the conducting zone has both cartilaginous airways and non-cartilaginous airways. So which ones are cartilaginous? Trachea, mainstem, lobar, segmental, subsegmental. Which ones are non-cartilaginous? The bronchioles and the terminal bronchioles. All of those are part of the conducting zone, but I might ask you which of the following are non-cartilaginous parts of the conducting airways. You would answer me bronchioles and terminal bronchioles, right? I hope that makes sense. The whole point of that transitional airway is still conduction. It's not gas exchange, it's the movement of gas. All right, the trachea itself, let's talk about that real quick. In the adult, it's about 11 to 13 centimeters long, so 11 to 13 centimeters long, 1.5 to 2.5 in diameter. These are important numbers. I will expect you to remember that. It descends from the cricoid cartilage to the second costal cartilage. So that was supposed to be me putting a C for cricoid. It did not work. So it's from the cricoid. Remember that complete tracheal ring? So from the cricoid cartilage to the second costal cartilage. So if you have room to write it in, write cricoid in there, right? To the second costal cartilage. The second costal cartilage is where we see what's called the angle of Louis. The angle of Louis, also known as the sternal angle, is a landmark that can help tell us where the carina is. And you're like, why would I have to know that? If we go to nasotracheal suction someone, so it's called NT suctioning, we need to know where the carina is, because remember what happens, what type of stimulation happens when we hit the carina, right? It's that vagal stimulation. So when we hit the carina, their heart rate would go down, their blood pressure would go. That can be dangerous. So if I measured from someone's nose to the tragus of their ears, and then from the tragus of their ear to the sternal angle, or the angle of Louis, then I would actually know how deep it is before we get to the carina. So then I would know that length, and I would subtract like a centimeter or two from there, so that way I wouldn't be hitting the carina and avoid all that vagal stimulation. So the angle of Louis is roughly where the carina is behind that. So you can feel this on yourself. If you feel your collarbone, so feel around for your collarbone, right, and you're going to feel this, that's the notch where it all comes together to the sternum, and then start palpating your sternum and go down, and you should feel that bump, and that's the angle of Louis. Now, the angle of Louis, there's a fun story behind that one, and it won't test you. If anything, it would be a bonus question or something like that. But the angle of Louis is also known as the sternal angle, and there was a French surgeon that came up with this, and he's not known as much for naming the angle of Louis, and of course his name was Louis, but he is actually more known to invent the guillotine, right? And this is in the 1700s, where he actually created the guillotine. He was a physician, and he created the guillotine because he was tired of seeing people hung as a death sentence, and so he's actually more known for inventing the guillotine. Isn't that crazy? Okay, I hope you like my crazy story times. They're just fun. All right, as the division of the trachea is called, and that's the last thing to write in here, is the carina. The carina, C-A-R-I-N-A. Right, so this is actually an important landmark. We also need to know, too, if we're going to do an EKG on someone, where their fourth intercostal space is. Well, we know if this is at the second intercostal space, you just feel 2 ribs down and you're at the fourth intercostal space, and you can then start your EKG. This is just a different picture. This is why they call it the sternal angle. You can see if they put these 2 cotton tip applicators together, you can see it forms an angle. It changes direction, and that's what you're looking at there, the angle of Louis. All right, so more about the trachea. I hope you love the information on the trachea. 15 to 20 C-shaped rings, and this is what you're looking at here. So this is anterior down here, and it's closed posterior. So the posterior part of the rings are adjacent to the esophagus, right? That's that part that you use to drink and eat, get that food and water into your stomach, right? And this is connected fibers of the trachealis muscle. So instead of me writing in there, I just pointed right to it. Trachealis muscle. The trachealis muscle, the way that I remember this is Alice in Wonderland and her going through a rabbit hole, and that's how I remembered it. I don't know if that makes sense to you. It made sense to me when I was looking at this. So this is where it's incomplete posteriorly, and this is actually a landmark that we look at in bronchoscopy to tell right lung from left lung is, hey, where are the tracheal rings incomplete? That can actually give us a landmark to which side is the right main stem and which side is the left main stem when we're actually going in there with the camera. It's pretty cool. All right, so this is the big picture as we're going through the lungs, the trachealis muscle. Remember, the esophagus is posterior, and so we can sort of see that you won't see it in this view, but one of the things I do want you to see on this view is the angles of the right and left main stem. So as we're going down the trachea, and then we're going to the right main stem and the left main stem, notice that they're at different angles. That right main stem is roughly about 25 degrees, and that left one is probably about 40 to 60 degrees, depending on your height and all that stuff. So that's going to be a big factor when we start to look at different conditions. So let's say someone aspirated some corn dog. It's happened. I'm not making this up. And so the corn dog went into their trachea. Which side is more likely for that corn dog to go down, the right main stem or the left main stem? That's right, the right main stem bronchus, and that's where you might see issues where someone aspirates food or vomit or anything like that. It's more likely to cause that right lower lobe pneumonia. It's kind of an interesting pathology that you could have going on there. All right, so this is just a different view, a more boring view, I think, but it's still there. I like this picture, though, a lot better of looking at the trachealis muscle and the esophagus and the mucus glands. So much better picture. I love this picture up here. Gives you that better picture, and also you can sort of see the right main stem down here when we're looking at this is shorter than the left main stem. You notice, see how the left main stem is longer, but the right main stem is wider and shorter. So obviously this will date me. I always name this one George Costanza. Hopefully that makes sense to you. And this one I named Kramer. So the Kramer was a tall, thin individual, and George Costanza was not. He was more of a shorter, wider individual. Nothing against him, that was just a description, and that's how I remember the right main stem being shorter and stockier than the left main stem that's longer and thinner. Different angles, one's at 25, the other one's at 40 to 60, so I like this slide overall because it gives you good views of both the trachealis muscle and the relationship between the trachea and the esophagus, as well as the right and left main stems and some characteristics of them. So the main stem bronchi are the first generation of the tracheobronchial tree. I know there's 28 of them, so put your seatbelts on and get ready for a trip here. The right main stem bronchus, right? The right main stem, so I'll put that in here. The right main stem bronchus branches off the trachea at a 25-degree angle, and the left bronchus forms a 40 to 60-degree angle, so that's much different, right? And the right bronchus is wider, more vertical, and shorter. So you do need to remember that. The right bronchus, and I called this one George Costanza, right? You can Google image if you don't know who that is. And the left is Kramer. It's smaller, taller, and that's on the left. It's a different angle, and that character was kind of a different angle too. So this is going to be important because remember, flow of gas or liquids or food, if it goes into the trachea, will go the path of least resistance, which is usually that right side. So less often for that left side. So we're intubating someone. Let's go to the next slide. If we're intubating someone and we're putting an endotracheal tube into someone's lungs and we go too far, which side is it most likely going to go down? Well, the straighter path is going to be that right main stem bronchus. So if you're intubating someone and you only hear breath sounds, or you only see the right side of their lungs move, their chest wall move, then you know that that tube's probably too deep and to pull back, right? Pull back on that tube just a bit, a couple centimeters, and then see if you see bilateral chest rise after that. This one also shows the 25-degree angle, and I know it says 20, so pay no attention to these numbers. They don't exist, right? I want you to know 25 degrees for the right main stem and 40 to 60 for the left main stem. So it shows the wider, shorter right main stem, and then it shows the longer, taller main stem for the left. Why? Why is there a difference between the two, especially on an adult? Why is there such a difference? Well, there's a 4-pound structure that's located right around here. It's more on the left side than the right. So every time you weigh yourself on the scale, subtract 4 pounds, because 4 pounds of that is your heart. You kind of need it. And that's why, because this has got to go around the heart to go to the left upper lobe and the left lower lobe. So that's why this is longer. Right? And the right side, you don't have much of the heart on the right side. Most of it's on that left side there. So that's why, and even in neonates, a newborn baby, you're still going to have, or infants, you're going to have it closer because of the thoracic size, but still there's going to be more prone. If you were intubating, they're still going to have more prone for that ET tube to go down that right side still. This is also a good picture. I like this picture a lot here, but it shows how straight of a shot that right main stem is compared to that left main stem, and how much shorter this is, because remember, we have that start of that right upper lobe pretty quickly there. And the left side, it's got a lot longer to travel before we go to the left upper lobe, and the left lower lobe is down here. So this would be the left lower lobe, this would be the left upper lobe, here would be the right upper lobe, right middle lobe, and right lower lobe. So the main stem and the lobar bronchi, the main stem bronchi are supported by C-shaped rings. We already talked about that. Each one runs obliquely before in the mediastinum. And the mediastinum is the area where the heart and the lymph tissue and the trachea and all that stuff, that's where all that stuff is, right? It's in between both of the lungs. That's the mediastinum. And where the main stem attach and go into the lungs, well, that's called the hilum or the hilus. Right, that's where it goes in and attaches itself. So the mediastinum is where the esophagus, like I said, the trachea, the phrenic nerves, the lymph nodes, the thymus gland, all that stuff's going to be in that mediastinal area. Okay, so the next bullet point there, inside the lungs, the main stem or primary bronchi divide into lobar or secondary bronchi. So you have 3 on the right and 2 on the left, which supplies a lobes, which should tell you then that you have 3 lobes on the right and 2 lobes on the left. And I just highlighted that in a previous slide. 3 lobes on the right, 2 lobes on the left. Why is there only 2 lobes on the left? Because there's got to leave room for that guy, that little heart thing. It's pretty important. We need something to circulate all that oxygen. This is the top view. So this is where we're looking at the lobes. So here we see the right upper lobe, right middle lobe, and right lower lobe. Right upper lobe, right middle lobe, and then right lower lobe. And then here we see the left upper lobe, and then the left lower lobe. And that's what we're looking at here. So this just shows you the different lobes of the lung. I wish I had a 3D model that you guys could handle and sort of see how the lungs are bigger posteriorly compared to anteriorly. This is a 2D picture of a 3D object, and it's just not fun for you guys, and I'm sorry. But hopefully maybe one day we can like 3D print some good lungs for you, and you can actually sort of palpate and feel, or get you into cadaver lab or something like that that has you sort of be more hands-on and appreciate this more. The bronchi and subdivisions, we have lobar bronchi that become segmental bronchi, and now we're getting down in generations. Remember, trachea is the first generation. Now we're getting to the 10th generation. We're getting pretty far down, or sorry, the 9th and 10th. Sorry, the 9th generation is where we're at now. I haven't gotten to the 10th yet. So we have 10 pulmonary segments on the right lung and 8 pulmonary segments on the left lung. And I will make you guys memorize this. This is, once again, important numbers that I will ask you on an assessment document. So why? Why would I ask you these things? A couple reasons. The board exams will ask you, hey, they'll show you a picture of someone in a unique position. It'll be like, hey, what bronchial segment is being drained here? And you'll actually have to know the name of it and the location of it based upon what the position the patient's in. Kid you not, all right? That's a board exam question, so that's something you will have to know for both practice and for daily for your NBRCs, for your board exams. The other time, too, is you'll need to know these if you're doing a bronchoscopy. So if you're assisting with this, you might be going down the right main stem and you see 3 segments in the view and it looks like the holes of a bowling ball. Well, where are you at? Well, you're in the right upper lobe because there's the apical, posterior, and anterior segment in the right upper lobe. And so now you're grabbing a sample and you label the sample right upper lobe, you know where you're at based upon the segment. So the right upper lobe has 3 segments, the right middle lobe has 2 segments, and the right lower lobe has 5 segments, and then the left upper lobe has 4, and the left lower lobe has 4 segments. So you're going to sort of see that you'll see those divisions a little bit, especially if you're watching someone do a bronchoscopy. Have them see if they're willing to talk about and point out the different anatomical areas, so you'll be able to see it. So if I look in the bronchoscope and I see 5 segments in the distal view, then I know we're in the right lower lobe. And then I might actually have to know the subdivisions there, especially when we're looking at therapeutics down the road. So you will be expected to know the names of those as well as how many are in what lobe. Whew. Yes, the joy of it all. I can feel the joy based upon just hearing that news. So the segmental bronchi are about 1 to 4 millimeters in diameter. They have parabronchial sheaths with all the vessels, the lymph tissue, and all that stuff. And now we're getting to the 9th generation. Sorry, I said 10th generation, but I was a little ahead of myself there. And this is what we're looking at here. I love this picture. I would like to have this model one day. So this is the right upper lobe, the apical, posterior, and anterior segment, the right middle lobe, and the right lower lobe. So remember there's 5 down here, 2 here, and 3 up here. And that's what you're seeing here. You see these subsegments, right? You see 2 over there and 1 up top. And then here are your left upper lobe. And then here you see 4 segments all together. 1, 2, 3, 4. And then your left lower lobe, which you should see 4 as well. That's what you're looking at here. So you do need to know the names for all of them. That's in your book. And I have a fun way of memorizing that. We'll get into that later. Alright, so now we're going down to non-cartilaginous airways. So this is the transition zone. So remember, this is still part of the conducting airway, but this is the non-cartilaginous part of the conducting airway. And these are less than 1 millimeter in diameter. We've already talked about that. There's no connective sheath here. We're changing function. So there's no, or a lot less rigidity here. And so this can move and actually be compromised by things like mucus and air trapping and things like that. This one has a different, its patency can be compromised, but it has a different way of sort of maintaining its structure. The structure is a lot less rigid, but it's still there, and it's a smooth muscle. So I'll just put SM here. The SM stands for smooth muscle sheath that surrounds the bronchial. So that means when someone has a bronchospasm, like with asthma, that it even closes down the airways that lead up to the gas exchange, which means their ability to get oxygen into their bloodstream and CO2 out of their bloodstream diminishes. Isn't that crazy? So that smooth muscle sheath will close down and clamp off. So here, let me draw a transition zone, and then let me draw a respiratory zone. So this is my transition zone. It has that smooth muscle. It constricts and shuts off the ability for gas to get in there. So the gas that's in here that has like CO2 and all that stuff just keeps building up and building up as blood keeps dropping off CO2 and stuff, right? And so we got hyperexpansion going on now of the alveoli, and none of that gas is coming out. So we got what's called air trapping, and that can happen with asthma, can happen with emphysema, where these airways become really floppy and destroyed with emphysema. So that means when the patient starts exhaling, these airways will collapse on them and then trap a bunch of gas in their respiratory zone, and then it causes hyperexpansion and then destruction of the airway ultimately. Pretty crazy. When we're looking at the transition cell, remember we talked about it, that it has the pseudostratified columnar. By the time we get down here, the columnar epithelial cells become cuboidal. I was hoping you guys remembered it. Cuboidal, right? Remember those cute cubes that were lined up? Right, when we were talking about new cell types, this is where we get to generations 10 through 15. And your book breaks this down as well. Right, this is what we're ultimately looking at here. We have our cartilaginous rings as we get further and further down. Notice that there's less cartilage when we're looking at the terminal bronchioles and the bronchioles. This is your transition zone right here, right? Let me pick a different color. This is your transition zone right here. Your bronchioles and your terminal bronchioles. They're not your respiratory zone, they're your transition zone, which is ultimately under your tracheal bronchial tree, right? Your tracheal bronchial tree is everything up till the terminal bronchioles. The terminal bronchioles is where your tracheal bronchial tree terminates. Anything past the terminal bronchioles is considered respiratory zone. So different function altogether. Okay, so notice that the bronchioles and terminal bronchioles here, they don't have cartilage there. They might have some plate-like cartilage sort of left over, but that's not really functional as far as structure goes. So bronchioles and terminal bronchioles, non-cartilaginous, part of the tracheal bronchial tree. Right, their diameter is about 1/2 millimeter, so pretty small airways. The cilia and the mucous glands, they should progressively disappear by the time it gets down here. It has cuboidal areas. Cuboidal does not have the cilia. It has something called the channels or canals of Lambert. So the, what color do I have here? Canals. I'll spell it because I don't have enough room to write it. CANALS of Lambert. So LAMBERT. Canals of Lambert. This is where they start to appear, and they connect the terminal bronchial to an alveoli. And there's a good picture on one of the slides here. So you're going to see this airway that's a terminal bronchial, and then you're going to see sort of an alveoli sticking to it, and it's going to have that communication in between the two. That means that if there's some mucus plugging or something like that going on with an alveoli, we can actually go around that mucus plug and still have exchange of gas. It's like an alternate route. So let's say a highway is closed because of some reason or another, and they're going to make you take a detour around some road construction, right? So this is like a detour that helps get gas and mucus moving around different things. So this is a term known as collateral ventilation. So it's just an alternate route, a way of a detour, a way of getting around difficulties. So don't worry about that too much. Also, in the transition airway, you have the presence of club cells. So your book still calls them, unless they've updated your book, Clara cells. So if you see it, you're reading your book and you're like, I don't see the word club cells anywhere, they will call it Clara, C-L-A-R-A. Most scientific journals and resources out there call them club cells now. There's a whole story about where the Clara cells came from. It was a German doctor during World War II. Of course, you can put your imagination into how he came up with discovering these and naming them. So a lot of international societies have gone to renaming them club cells now. So your book still calls them Clara cells. However, most groups and text out there will call them club cells now. Well, the function of these cells, we don't really know, but we do know that they have some extensions in them, like some protoplasma anaerobic extensions in them that can help possibly detoxify anything that you inhale. So it's like one last protection mechanism before you get to the respiratory zone. And so that's one of the things that they think they might have, that they might do, but it's still sort of unknown their full extent of their purpose. Structures beyond the terminal bronchioles, this is something I already talked about, are not considered part of the tracheobronchial tree. That means it's like seeing a tree in the middle of winter without any leaves. That tree can exist without leaves, it's just in hibernation, and anything beyond it is something different. So the leaves of that tree, if you're using that analogy, would be something different. That would be the respiratory zone. Right, this is where gas exchange happens. The reason why they want to separate these two is the function is different. Remember, the whole function of the tracheobronchial tree is filtering, protecting, right, moving gas, and the whole function of the respiratory zone is the exchange of CO2 and O2, right? So we have a different function, and that's why we end it there, right? We end it at the terminal bronchial. Past the terminal bronchial, it's something completely different because our function is completely different. All right, this is the Canal Lambert slide. I love looking at this one because it's showing that collateral ventilation. Here, let me go to yellow. It's showing that collateral ventilation. It's showing that communication in between a terminal bronchial and an alveoli. And here's the big picture up here. So that allows gas to move in between these two. So let's say, look at that picture up the top part there. There's a giant mucus plug up here that's blocking gas from going into this whole alveoli. Well, if we still want to use the alveoli, we can. We're going through this adjacent terminal bronchial, and hey, there's a channel that's opened up in between the two. So I'm going to go here, I'm going to go across, and now I can fill this whole area. I'm going to use blue for oxygen. I can fill this whole area with gas, with good oxygen-rich, and then I can get rid of my CO2 also through this Canal Lambert. So it's just an alternate route to get around. That's the definition of collateral ventilation. All right, so this is where we're going to be at now. We're going to start talking about the respiratory zone. So anything here. So your respiratory zone includes the respiratory bronchioles, the alveolar ducts, the alveolar sacs, and the alveoli themselves. So you do need to know those are the areas of the respiratory zone, and that the respiratory zone is non-cartilaginous. Where does the respiratory zone start? It starts at the respiratory bronchial. Where does the tracheobronchial tree end? It terminates or ends at the terminal bronchial. I like these pictures because it shows you sort of the vascularity and how much blood flow there is, and it sort of gives you that better picture of what we're seeing here as far as the surface area when we're going into the lungs and why that's important. So just a quick overview of where we're at. As the conducting tubes become smaller and smaller, the cartilage support changes. We've got less and less cartilage. Well, why? Well, remember, we're changing function, right? We're changing our function, right? We're going from conducting gas, like the bulk movement of gas, to gas exchange, right? So we have that whole change of purpose that's going on. The epithelium, so the next bullet point there, the epithelium changes. It goes from ciliated to cuboidal. Why? Well, you're going to get tired of this answer, right? Our function changes. So that's a whole thing where we're going from all the way down to simple squamous, right? So we go from conduction of gas, right? We go from filtering particles and moving dirt and dust and all that and pathogens to now going to very, very thin tissue for gas exchange. So that's why our cells change. That's why we go from pseudostratified ciliated columnar to simple cuboidal to simple squamous. The number of cilia and goblet cells decrease. Well, why? Well, you already know the answer to this. It's the change of function, right? We're going from needing mucus and cilia to clean out our lungs to being thinner, where we can actually diffuse gas across the alveolar capillary membrane. Why does smooth muscle increase as we go down? Well, that's a little different. Why would it increase? Well, smooth muscle will increase as we go down because remember, the only thing that keeps structure when we get down past the transitional or into the transitional airways is that smooth muscle. So that's what's left over, is the smooth muscle to sort of give it some rigidity besides elastic tissue. And the elastic tissue, remember, it's like a rubber band. It's going to be a resting state in a very small lumen. And so the only thing that sort of gives it some distension there is that smooth muscle too. Right? Our function is changing. Good answer. All right, let's talk a little bit about physics. Who doesn't love physics? So Reynolds number in the alveoli itself, right, is 1. That means gas flow. Once you're in the respiratory zone, the cross-sectional area of the lung will increase exponentially. So because remember we had dichotomous branching, we had a branch, and then off of that branch, we had 2 branches, and then off of that branch, we had 2 branches. Then off of those branches, we have 2 branches, right? So this is that whole dichotomous branching thing that we were talking about. So the further and further down we get to the airway, the more surface area we're going to get. And as we do that, sort of like a garden hose, right? If you have a garden hose and hook it up to your one spigot of your house, you're going to have good flow out of there. But let's say you put a splitter on there, and then you put a splitter on the splitter, and then you put another splitter on the splitter, right? You keep splitting and dividing up your garden hose pressure. What happens to the amount of pressure by the time you get to the end of that hose? They're all going to have very low flow of water because you've changed the amount of flow that can go to that one hose end off of putting all those splitters onto your hose. So I don't know if that helps, but the bulk movement of gas flow, by the time you get down there, it's not laminar, it's not turbulent. The movement of gas is molecular. And so what does that mean? Well, this is where we start to get into all this stuff. In your venous blood, you have more CO2 than you have in your alveoli. So we have a pressure gradient And we'll go into more detail in chapter 4. We have a pressure gradient, a higher amount of CO2 in our blood than is in our alveoli, so CO2 will diffuse in. We have a higher pressure of oxygen, and I'll use green here, higher pressure of oxygen in our alveoli than we have in our venous blood, and so we'll go that direction. We have a pressure gradient. We have a molecular movement of particles that's going on here, molecular movement of gas. So it's not the actual flow of gas, it's more the gradients that we're looking at as far as the diffusion goes. Now, as far as this also goes, and we'll get into it in further detail, this also looks at things like hemoglobin concentration and how much red blood cells we sort of have going through there. And then we'll look at the Bohr versus the Haldane and how that exchanges CO2 and O2 as well when we're looking at this. So just for now, the big thing here is the bulk movement of gas flow is molecular by the time we get to the alveolar capillary membrane, right? There is no bulk movement of gas flow. We've done so much splitting of our garden hose that there's almost no flow coming out the end of it. And so that's how we actually exchange the gas, is molecular movement. It's kind of cool. And this is just a different picture looking at the cross-sectional area. So the conducting zones up here in the red, not a lot of stuff going on there, but as we get further and further down, closer to the 28 generations, see how it increases exponentially, right? Your cross-sectional area, as you get further on in the generations, will increase pretty dramatically. And this is going to be, 70 squared meters, or 70 meters squared, is going to be your cross-sectional area when you get to the respiratory zone. That's huge, right? So remember, what are the constituents of my respiratory zone? Well, I have my respiratory bronchioles, my alveolar ducts, my alveolar sacs, my alveoli. You need to remember these 4. This is important. Looks like it would be a test question. I'm just saying. Or a quiz question. When you're looking at the respiratory zone specifically, right, we talked about what's in there, right? The bronchioles, the ducts, the sacs, the alveoli. When we're in there, there's 3 generations of bronchioles. There's 3 generations of ducts, and then it ends in 15 to 20 grape-like clusters called alveolar, ALV, sacs, SACS. So 15 to 20 alveolar sacs. So these units, the respiratory bronchioles, the ducts, the alveoli, all have a term. So these are all synonymous terms with the respiratory zone. And even in this lecture, you're going to hear me say some of those terms. So it's important. I will test you on these alternate terms for the respiratory zone. And the reason why I want you to know this, like I already said, is a lot of texts, a lot of studies will use these synonymously, so that way you still know what they're talking about. So the first term is the primary lobule, P-R-I-M-A-R-Y, primary lobule. So if someone says, hey, during pneumonia, the primary lobule has a lot of inflammation, that's what they're talking about, the respiratory zone. Remember, these are all different terms for the respiratory zone. The next one on the list is the acinus, A-C-I-N-U-S, A-C-I-N-U-S. So the acinus is primarily affected with pneumonia. That's what they would be saying. That's just a different term for the respiratory zone. The next term is the terminal respiratory unit. The terminal respiratory unit, just an alternate term for the respiratory zone. The lung parenchyma. Well, let me spell that one. P-A-R-E-N-C-H-Y-M-A. The lung parenchyma is an alternate term for the respiratory zone. So if they say, hey, with emphysema, the lung parenchyma is the primarily affected site. Well, that's just saying that the respiratory zone, right, they're synonymous terms, is primarily affected. Then the last one at the bottom there, the functional units. That's good. I like that description a lot. Not as much as respiratory zone, but the functional units I like a lot, because that tells you where the actual exchange, where external respiration happens. So the functional units. right? So this is what we're looking at here. We're looking at the respiratory zone, ultimately all the way down here, the rest of this, tracheobronchial tree. Okay, this picture here I like a lot because it sort of shows where the canals Lambert. These are just different views, and you can see how there's like a terminal bronchial here, and there's an alveoli touching it, right? And that's where you would see that canal Lambert. And then as we get further down, we got the alveolar ducts, the alveoli themselves, and then the alveolar sacs, which is everything all together there. The alveoli itself, it's a smooth muscle fiber, ultimately. That's what can give it its structure. Remember, it's made of simple squamous, but it has a smooth muscle fiber as a constituent. There are approximately 300 to 350, so 350 million alveoli, which are 90% covered with capillaries, right? That's good. We want a lot of capillary coverage, right? That's how we get blood to get rid of CO2 and blood to pick up oxygen. So as I said before, this surface area of the alveoli, if I were to take all your alveoli apart and lay them down, it would cover the size of a whole tennis court, right? 70 square meters. That's huge. And this is a better picture. I like this one. It actually shows the smooth muscle that's going around this whole thing. The elastic fibers is a pretty important thing to remember, especially when we start talking about time constants. I know this sounds joyous to you, but how the lungs expand and collapse, the elastic fibers will play a key role, especially when we're looking at things like emphysema. Alveoli themselves, the alveoli, so we're getting further down. The alveoli are made of 3 cell types. Type 1 cells. Type 1 cells are squamous. S-Q-U-A-M-O-U-S. So they're squamous epithelium. That's what goes there. They're 95% covered of the alveolar surface. They're 0.1 to 0.5 microns, micrometers thick, and this is where your gas exchange happens, right? This is the alveoli and the capillary. This is where this whole communication is taking place to exchange gas, right? That's the whole major side of gas exchange. You also have another cell type that's in the alveoli. And these are called granular pneumocytes. So granular, G-R-A-N-U-L-A-R, and then the second one is pneumocyte. So P-N-E-U-M-O-C-Y-T-E-S. So granular pneumocytes. These have little microvilli on them. They're cuboidal, so they're sticking out in there, and they produce something called surfactant. Surfactant is going to be very important. Surfactant neutralizes Laplace's law, and when we're looking at surfactant, this is something people even add to their lawns, and it helps reduce surface tension of water. And normally your alveoli is going to have sort of some water that hangs out in there, not a lot, but we're reducing the surface tension. We're repelling water from water, so we're trying to help stop the attraction of water to its own self, and therefore help keep the alveoli open and distended, and this will form the remainder of the alveolar surface. And this is important, especially, let's say there's a premature baby that's born and they don't have surfactant that's mature yet because they're not supposed to be outside breathing yet. Well, then we're going to have an issue here where the pulmonary surfactant is not functional. It's not matured yet. And so what's going to happen with their alveoli, it goes from this nice open one to being collapsed state over here, and then is it going to have a lot of gas exchange in its collapsed state? Absolutely not. So that baby's ability to get oxygen and CO2 is going to be pretty diminished over there. So surfactant's a pretty important thing with type 2 cells. Type 3 cells are also known as alveolar macrophages. So alveolar, A-L-V-E-O-L-A-R, macrophages, M-A-C-R-O-P-H-A-G ES, alveolar macrophages, and these will migrate through the bloodstream and they'll go into the alveoli. and they just sort of do their phagocytotic action, right? They love to eat. Okay, so this is a different picture. This is looking at the tight space and the loose space, and we can also see um, the capillary here that's surrounding. Here, let me go to yellow. The capillary that's surrounding the alveoli, and here's the alveoli itself. Here's a pore of Kohn, and we'll talk about that in a second. We already talked about the canals Lambert, but not the pore of Kohn. The pore of Kohn are in between adjacent alveoli. So here we see an alveoli and one right next to it. Well, if they had a hole in between the septa that connect to them, then that would be what's called a pore of Kohn, just like pores of a skin. And so that means we can let gas through there, like collateral ventilation, or macrophages can go through there. So it's a pretty neat little thing that we can use to go in there. So the pore of Kohn, the first one here, just, I don't know why I blinked that up, but pore of Kohn, just write Kohn in there. The pores of Kohn, these are small holes in the alveolar wall or intraalveolar septa, like a septum of your nose. They allow gas to move in between alveoli. This is just another form. So between the canals of Lambert and the pores of Kohn, these allow for that communication. They allow for collateral ventilation. And this happens the older you are, the more of these you got. Congratulations. As we get older, we have degeneration that normally happens. And this is allows these pores to develop more and more as we get older. They're usually pretty small. They're only about like 10 micrometers in thickness. And the cool thing here is it can allow macrophages to actually travel through there, so we can actually have a lot better, not only collateral ventilation, but better recruitment if we need to have some more phagocytosis in this area. This is actually named, so a little side note, and I won't make you guys memorize it. There's a guy named Hans Kohn, right? I thought it always sounded cool, like Han Solo. His name was Hans Kohn, and he was a physician in the 1860s, and he's the one that ultimately had it named after him. So not a Nazi, right? But it's unknown really what the true function is, but we know it does have function, like it has benefits to it overall. So the older you are, the more likely you are to have more pores of Kohn. Pores of Kohn are in between neighboring alveoli. The canals of Lambert is alveoli to terminal bronchial. So there's a difference between the two. You do need to know the difference. Alright, so in the type 1 cells and type 2 cells, the type 2 cells secrete, and we already talked about it. Remember, repetition is the key to this, is the type 2 cells secrete surfactant. And I'll just write surf. Surfactant is surfactant, surfactant. The surfactant is ultimately what is going to be in there that helps reduce surface tension and keep the alveoli open. You also have the pores of Kohn that connect adjacent alveoli, so that would be adjacent alveoli there. And then you're going to have connect, and then I just put adjacent alveoli in there. That's what I put there. You have alveolar macrophages, and another word for these are called dust, D-U-S-T, dust cells. So dust cells that crawl along the alveolar surfaces, eating away at bad stuff. Here's one of these guys here. All right, what about the rest of it, right? Remember, there's not 100% covered of the alveoli with the capillaries, right? There's some areas that do not have capillaries at all. And so what are those? What do we do with those? Well, surrounds, the interstitium is what we're looking at here. It surrounds, supports, and shapes. There's supposed to be an H there. Shapes the alveolar capillary clusters. It has some molecules around it and some collagen fibers. This is the space that's sort of between and around the alveoli. So between and around the alveoli is this sort of interstitial space that includes collagen fibers. So there's two subdivisions of this interstitium. You have your tight space and your loose space. And this first one here is the tight space, and this is the area between the alveolar epithelium and the endothelium of the capillaries. This is where the gas exchange happens. So this is the communication between the capillary and the alveoli. So if I ask you which one is the communication or which one is the site of gas exchange, you would say it's the tight space, where the alveoli and the capillary are together. They're spooning, right? They're together, right? They're exchanging gas. And then you have your loose space. The loose space down here surrounds the bronchioles, duct sacs. It's more here where we have lymphatic tissue and neural fibers that control this area. So that lymph tissue becomes pretty important, as we'll start to see. So this is a better picture than what I can draw here. This is the tight space here. Let's go to yellow. Tight space here, right, with the capillaries in communication with the alveoli for gas exchange. This is the loose space where we have a bunch of lymph tissue hanging around, and neural fibers, collagen fibers, all that good stuff here. So this is a bigger picture. I always like looking at the large pictures and even larger pictures. As we zoom in, this is the alveoli, and then here's the alveolar capillary membrane. So here's the capillary, right? You see the red blood cell? And then here would be the alveoli down here. So it's that diffusion of gas across this area that I'm coloring in right now that we're looking at this, that gas exchange has to happen. So the bronchial blood supply. So as we're looking, so this is sort of something new, so if you need to take a break and pause, go do it. The bronchial blood supply, so just like your heart muscle needs its own blood supply for the muscle tissue itself, that your lungs also need this, right? The trachea, your stratified, pseudostratified ciliated columnar, like all that stuff, it needs blood supply. So let's talk about how blood is supplied to the tissue of the lungs, right? We're not talking about through the lungs to pick up and exchange gas. We're talking about just to keep the tissue of the lungs going. Well, approximately 1%. Why is it not working? 1% of the cardiac output will serve or go to the tracheobronchial tree. So you have your bronchial arteries that branch off the aorta and bring blood to the tracheobronchial tree as far as the, what's the last part of the tracheobronchial tree? Don't let it terminal you, right? The terminal bronchioles. The terminal arteries are also there. They also supply blood to the mediastinum in the pleural space as well. So we have some good blood supply. So 1% of the cardiac output will serve the tracheobronchial tree all the way down to the terminal bronchioles. So of that 1% that goes to the tracheobronchial tree, some of it will dump into the right atrium. This is good, right? So here, let's do the tracheobronchial tree, right? So off of the aorta, so let's go to red. I have good oxygenated blood that's going to the lungs to supply the lung tissue with oxygen-rich nutrition and all that stuff so the lung tissue can continue to live. Well, once it gets used, it'll go to purple. Or I guess I should just go to blue. Let's go to blue. Once it's used, it dumps into the right atrium. Okay, so it dumps its used blood into the right side, which is good because that's where all the bad blood's supposed to go. So what vessels are responsible for this? You have your azygos, and you do need to know these. Your azygos, A-Z-Y-G-O-S. Your hemiazygos. So H-E-M-I, azygos, A-Z-Y-G-O-S. And finally have your intercostal veins. So those are the three vessels that dump into the right atrium. That's good. So they don't go into the right atrium, then they go through the tricuspid valve into the right ventricle, then from the right ventricle through the pulmonary semilunar valve to the pulmonary artery, from the pulmonary artery go to the lungs to pick up oxygen. Then once it does that, switch over to red, assuming we picked up the oxygen, then we go from the lungs through the pulmonary veins into the left atrium, and then in the left atrium we go through the mitral or bicuspid valve into the left ventricle, then into the aorta, and then if it wants to, remember only 1% of it will go here, but the rest of it will go to the systemic blood flow, right? The rest of the bronchial venous return, so some of it will dump into the right atrium. The rest of it will drain into the pulmonary circulation, into the pulmonary arteries and capillaries. And there's a fancy word here, and this is how it goes. It's called the bronchopulmonary anastomosis. Let me spell that for you. So these are two words. First word is bronchopulmonary. So bronchopulmonary is BRONCHOPULMONARY. And the second one is anastomosis. ANASTOMOSES. Bronchopulmonary anastomosis, which flows into the left atrium via the pulmonary veins. So we have used blood going into the unused side. So you get bad blood or deoxygenated blood with high CO2 that mixes with the high oxygenated low CO2 blood. So we have blood instead of, so remember we talked about 1% going back to the lungs and then dumping into the right atrium. But we also have some that dumps itself via bronchopulmonary anastomosis directly back into the capillaries. Isn't that crazy? Via what's known as bronchopulmonary anastomosis. That's what you're looking at here. The communication in between where the tissue is using this and dumping it in there is the bronchopulmonary anastomosis. And this is what's known as an anatomical shunt. Well, the anatomical shunt, it's also known as venous, V-E-N-O, venous admixture, A-D-M-I-X-T-U-R-E, right? So this is the mixing of venous blood into oxygenated blood. So notice that this turned purple now. So that means we have used blood going into the unused side. This is very little. We have very little that does this. This is less than 3% of your blood that's naturally doing this. You might ask, why? Why does my body do this? Well, I'm glad you asked, because you're asking why. Well, your body's doing this because you have this left over from fetal circulation. When you were in utero, when you were developing, you did not need oxygen-rich blood. You did not need to exchange gas to breathe because you were taking that from mom. And so you were using her oxygen, right, and all that stuff to supply your body with what it needs. And so your body naturally took blood and bypassed most of your lungs, and this was one way to bypass that and send it back into arterial supply for your blood vessels to develop. So this is just left over from fetal circulation is ultimately what we're looking at here. The pulmonary vascular system. The pulmonary vascular system is ultimately designed to deliver blood to and from the lungs for gas exchange. So we're done with what supplies the tissue itself. The function is to deliver blood to the lungs for gas exchange. But remember, we talked about the tracheobronchial tree getting all of its supply from the aorta, right? But what about your respiratory zone? Where does it get its oxygen supply? Or where does it get, its nutrition, right? It gets its nutrition, it steals it, right, from the pulmonary vascular system. So here we see the alveoli, here we see the blood vessel. So the alveolar wall, like the respiratory zone, the alveolar ducts, the alveolar sacs, they're going to steal nutrition from the blood that's going through the capillaries. Isn't that crazy? So that's how they get their nutrition. So within the pulmonary vascular system, we have it merging with going down to the pulmonary capillaries that merge with the alveolar capillary membrane. Right, the alveolar capillary membrane surrounds the alveoli. Remember, 90 to 95% of the surface is surrounded with these. So you have the right atrium going through the tricuspid valve to the right ventricle, through the pulmonary valve to the pulmonary artery, to the lungs, then through the pulmonary veins to the left atrium, which then goes to the mitral valve, which then goes to the left ventricle, which then goes to the aortic valve, which then goes through the aortic to the body and or back to the lungs for the tracheobronchial tree, but only 1% does that. This is what you're looking at for the big picture. I like these big pictures because it shows you like there in the middle. This is the whole hilar region. Let's go here. This whole area that I'm circling here is actually the mediastinum, where all the lymph vessels, the thymus, the heart, all the great vessels, all that stuff is there. And then where the lungs, where the main stem and the pulmonary artery and all that stuff connect into the lungs, that's known as the hilum. So this picture is pretty good at showing you a good way of looking at all this stuff, especially looking at all the smooth muscle and the exchange of gas, where it goes from the pulmonary artery up here, deoxygenated blood, and then being delivered to the respiratory zone, which then goes back to the pulmonary vein, which then will hopefully dump back into the left atrium. So I love these pictures. This is also a different way of showing the pulmonary artery going and exchanging gas and then dumping back into the pulmonary veins. So let's talk about the vascularity a little bit in depth here. When we're looking at this, we have the arteries that turn into arterioles. So this is as we're getting smaller and then back bigger again. Arterioles, then they go to the capillaries where gas exchange happens. And then we go back to venules and then to veins that then dump into the left atrium. So there are three layers. You have your tunica intima of the pulmonary artery. So we're starting there. Tunica intima, tunica media, and tunica adventitia. You do need to know those. The intima is the innermost layer. It's a thin layer. It's mostly connective tissue. The media is that middle layer. This is the thickest, densest layer. It has elastic tissue. It also has smooth muscle, so that can be affected by your sympathetic and parasympathetic stimulation as well. That's something that we can affect when we're doing things like a nitric oxide or a gas that is endothelium relaxer. It actually can relax smooth the endothelium, which is the tunica intima part, and actually dilate a pulmonary blood vessel. It's pretty cool. But we do have smooth muscle intervention here as well. And then we have the adventitia, which is the outermost layer, which will nourish everything else. These vessels are very stiff. They carry blood under high pressure because we need it to push itself and distribute throughout the lungs. The better distribution lungs we have, the better we can exchange that gas. So the pulmonary artery, stiff vessel, needs to be. The arterial, so we're getting smaller, right? This is the endothelial layer. It has an elastic layer. It has smooth muscle fibers. These are called resistance. So resistance, resistance. My stylet's not great, but I spelled it for you. They regulate smooth muscle. They use smooth muscle regulation to change the blood flow, so we can have a good match of blood flow to ventilation here, depending on what's going on physiologically with the patient. So they can help control that. So the capillaries, they surround 90% of the alveoli. They have mostly endothelial layer, just squamous, right? We need nice thin tissue here. And this is pretty much just the extension of the tunica intima that we're seeing here, right? And so it's that innermost layer that just extends and stays there, and we're just progressively unpeeling or losing those outer layers. And this is where gas exchange occurs, right? And that this tissue is so thin here, the capillaries are so thin, they're thinner than a hair, and you can only usually fit about pretty much one red blood cell at a time through there, but there's so much vascularity that we have tons of blood going through there. There's also a little bit of prostaglandins that are produced here, but and some other things that are destroyed, but that's not the primary thing that's happening. The most important life-changing thing that's happening here is that exchange of CO2 and O2. So once we've exchanged the oxygen and CO2, we go to the venules and veins that will drain back to the heart. So there's 3 layers, just the same as the arteries. 2 layers in the smaller veins. There's just no tunica adventitia. Remember, that's the outer thick, tough layer. And these are veins, so they don't need the outer thick, tough layer. They're draining back to the heart, so they don't need that. So the middle layer is very poorly developed, less smooth muscle and elastic tissue, so there's not much really holding it in. It's like going without your Spanx for a while. I don't know. If you don't know what those are, I don't know what to say. But due to less elastic and smooth muscle, they can hold a lot more blood volume, which is good, and that's why they're also known as capacitant vessels. CAP, so that's what goes back here. Capacitant, CAPACITANCE, capacitance vessels. So this is good. So as here, let me draw a heart. Okay, I'm drawing a 4-square heart. So let's say our left ventricle fails. Well, that means we're going to have not much blood being squozen out of that left ventricle. That means blood's going to back up into our left atrium. Okay, as blood backs up to the left atrium, it's also going to back up into our pulmonary veins. Right, we're going to back up. This is good because we can now expand these pulmonary veins and hold blood volume. Because what happens if these were just forcing blood into our atria and forcing blood into that ventricle, like squeezing it like an artery? Well, if they were squeezing it into there, we could cause more stress on that ventricle and actually cause the heart to go into further failure. The fact that these can back up and hold blood and save the heart from stress is actually going to help save the heart energy and hopefully help the heart tissue get better or heal, or give us time to let the heart get better and heal from our aspect. So that's actually a good protection mechanism. You want them to be capacitant vessels. Let's talk a little bit about the lymphatic system. We're almost done with the part 1 here. The lymphatic system, this is going to remove excess fluid and proteins, right? You already went over the lymphatic system in A and P. And so this is just going to be in the sheath around the bronchioles and in that loose space in the interstitial. Remember, we have the tight space where the gas exchange happens, and then we have that loose space where there was mostly lymphatic tissue. Well, this is where we talk about it. You have more lymphatic vessels, lymphatic tissue sort of, located on your left side than your right side, which means you're more prone to right-sided pleural effusions because it can't absorb as much fluid. So there's less drainage on your right side. So like veins, they have one-way valves or flaps, just like anything else with veins. The lymph nodes at the end of the line are located outside the lung parenchyma. Hey, what do you know about that term? Lung parenchyma, remember, is a synonymous term with the respiratory zone, the acinus, the functional unit, the terminal respiratory, right, so on and so forth. So, hey, there's an alternate term there, and we've seen it in our own lecture. What do you know? There are no lymph vessels in the alveoli altogether. They are located immediately adjacent to the alveoli, and they're called, get ready for this, see how that you have that whole line, juxta-alveolar lymphocytes. Juxta, J-U-X-T-A, alveolar, A-L-V-E-O-L-A-R, and then lymphatics, L-Y-M-P-H-A-T-I-C-S, juxta-alveolar lymphatic. So not in the alveoli itself, but directly adjacent. And this is what you're looking at here. And here, I love this picture here that you're looking at. You see all these little green dots. That's not the Mucus guy from the Mucinex commercials. Those are lymphatic vessels or lymph nodes that we can actually sample with endobronchial ultrasound. So if you hear me talk about EBUS, that's endobronchial ultrasound. That's where we take a bronchoscope and we have a ultrasound attached to the end of it, and we'll go and we'll actually core through. So we'll take a needle, stab through the airway into one of these lymph vessels or these lymph nodes, and we'll take a sample, and you, the respiratory therapist, will take that sample and put it onto a slide. Yes, you are actually doing this. You're putting it onto a slide and then giving that to the pathologist in the room that's looking for things like lung cancer and all that stuff. So it's a pretty interesting thing, and yes, it comes in handy. Like I just gave you an example where you actually will be using this information. So what are you doing during EBUS? Well, we're sampling lymph nodes that are in the trachea and the mainstem airway is to look for things like lung cancer. And we can get that diagnosis early on so we can treat them more effectively and ultimately have a better chance at a positive outcome. All right, neural control of the lungs. Once we're done with this, we'll move on to part 2. So this is controlled by the autonomic nervous system of your lungs. This is important when we're talking about neural control, especially when we get into pharmacology. So I'm giving you that base, that foundation for things like therapeutics, for things like critical care techniques when I talk about bronchoscopy, for things like pharmacology, right? So I'm here to supply you with the base for all those classes. And so this part is more of a base for pharmacology. So the control of the lungs is done by the autonomic nervous system, and it regulates involuntary vital functions like your cardiac muscles, right? Your smooth muscles and your glands, G-L-A-N-D-S, right? Those are all the involuntary vital functions. You can't control how much your lungs are secreting right now, right? That's not something you're automatically thinking about and controlling. It's autonomic, but it's not something that you could just mentally do. If you can, awesome. I want that. That's a cool superpower. I'm glad you joined the respiratory field. There are 2 divisions of the autonomic nervous system. You should remember this, right? You have your sympathetic and then your parasympathetic. Which one is your fight or flight? Well, that's your sympathetic. Which one slows everything down? The parasympathetic. I like the parachute analogy. My brain always thinks of a nice slow parachute slowing things down. All right, so the sympathetic or fight or flight system, what will that do to my heart rate? Well, that should increase the heart rate, right? You're going to see an increase or an elevated heart rate with that. Their blood vessels will constrict. Why is that important? Well, that is important because we need to raise blood pressure to send blood to our brain so we can think right, send blood to our muscles so we can run faster and harder. So that's important. So we'll constrict blood vessels that raise the blood pressure, right? If I have a hose here that's nice and open and I somehow clamp down that hose, what happens to the amount of pressure coming out the end of that hose? It increases, right? Because I made this lumen or the hose diameter smaller, right? So that's going to increase blood pressure. That's going to ultimately help send more blood to where it needs to go. And then it will relax or dilate bronchial smooth muscle. Okay, what about the parasympathetic? Well, that's going to decrease my heart rate. Remember, it's like a parachute. It slows things down. So it'll decrease my heart rate. My bronchial smooth muscle, instead of being at this nice, huge dilated state when I'm in my fight or flight, it's going to go to more of a baseline state, which is smaller. So we'll call it baseline. So the bronchial smooth muscles, we won't say constrict, we'll just say it's just a smaller lumen. So the bronchial smooth muscles will create a smaller lumen or a smaller diameter. It's not constricted. It's just at a baseline small diameter, right? It doesn't need to be dilated. And finally, the last one, this is going to increase your intestinal movement and gland activity overall. That's that digest part of this whole situation. All right, you have your sympathetic neurotransmitters. These are postganglionic. So preganglionic, you have ACH. Postganglionic, you have epinephrine, right? And then the other one is, I hope you remember it, norepinephrine, right? These will stimulate the beta-2 receptors that will let the bronchial smooth muscles dilate or relax, right? Same thing. So it lets the bronchial smooth muscles become larger, and so that way you can get more gas into and out of your lungs, so you can run faster, jump higher, do all that good stuff. You also have alpha receptors in the arterial smooth muscles that cause pulmonary vascular system to constrict. That's good because it'll actually force blood flow through there, which helps you exchange some gas. All right, last slide before we break. Parasympathetic neurotransmitters. Remember, acetylcholine is the only one in parasympathetic system, both pre and postganglionic, and this causes constriction of the bronchial smooth muscles. So inactivity of either the sympathetic or parasympathetic allows the other one to dominate. So if I have inactivity of my parasympathetic because I'm blocking it, then my sympathetic is going to take over. If I have lots of stimulation from parasympathetic, then my parasympathetic is going to take over, right? So we just need to pay a lot of care to what's going on here, especially when we're looking at medicine.